بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا، إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the third part of the topic of imaging of the soft tissue tumors. And you remember that there are about 12 categories of soft tissue tumors, and we have discussed in the first part of these lectures the topic of tumors arising from the connective tissue. Then we, in the second part, we have finished the imaging of fibrohistiocytic tumors, tumors of fat, tumors of the blood vessels, and the tumors of the lymphatics. Now we are going to discuss these topics: the tumors arising from the muscles, tumors arising from the synovium, and the tumors of the peripheral nerves. Then in the tumors of muscle origin are only four. Two arising from the smooth muscles, and these are the leiomyoma and leiomyosarcoma. Another two arising from the skeletal or the striated muscles, and these are the rhabdomyoma and the rhabdomyosarcoma. Actually, if you remember that leiomyoma is one of the soft tissue lesions or tumors commonly seen in the gastrointestinal tract, especially in the esophagus, and in the peripheral tissues. This is the common form of leiomyoma, which is known as angioleiomyoma. And this occurs typically in the subcutaneous tissue of the extremities, especially in the leg, as you can see here. Also, it can occur in the trunk, and commonly, also less commonly, in the head and the neck region. The tumor is usually small, in the range of 1 to 2 centimeters in diameter, well circumscribed, and is oftenly painful. Some calcium can be present in the tumor, and this is one of the criteria where you can see a vein that is going to the tumor from the through the subcutaneous tissues, and this is considered one of the differentiating criteria. Similar to any other soft tissue lesion, by ultrasound, and you can see a hypoechoic mass, and this is near the skin. By Doppler ultrasound, then you can see some vascularity near the margin of the lesion. And this is the pathologically proved angioleiomyoma of the hand, where you can see a mass in the first web space. It appeared of low signal in the T1, the high signal in the T2, with a significant post-contrast enhancement, as you can see in this fat suppressed image. And also you can notice that the tumor appears in the plain film as a soft tissue tumefaction with no significant bony changes in the related metacarpals. Another, the malignant form of these smooth muscle masses is the leiomyosarcoma, and this is considered an extremely rare malignant neoplasm. And it accounts for about 8% of the malignant soft tissue tumors. And this lesion was commonly seen in the gastrointestinal tract, and now replaced by the name of GEST tumor. Also, it can be seen in the vessels, like leiomyosarcoma of the pulmonary artery, leiomyosarcoma of the inferior vena cava. When it occurs in the extremities or in the soft tissues, it will have no specific imaging criteria. Then all what we can see is a tumor, and this is of almost iso-intense signal to the muscle in the T1 and of bright signal in the stair. If you inject contrast material, it will show some enhancement. And this is another lesion that has been proved as leiomyosarcoma in the leg. And here you see in the T2 weighted image, the tumor is of intermediate signal. This is T1, and in the stair image, the tumor is of bright signal. And this is the leiomyosarcoma in the calf, where you can see an iso-intense signal to the muscle in the T1 weighted image, and this is the T2 fat sat image, where the tumor is significantly bright. Then we came to the rhabdomyosarcoma, which is the malignant tumor of the skeletal muscles. And rhabdomyosarcomas are now thought not to arise from the skeletal muscles. And this is almost similar to the synovial sarcoma, as I will mention in a moment. Why its name? Because the tumor differentiates into a tumor which resembles the skeletal muscle. Then this fact explains that the tumor can occur in some anatomic places where no skeletal muscle is present. So this tumor is considered the most common soft tissue tumor in children, and it accounts for about 7% of childhood cancer. About 65% of these tumors are diagnosed under the age of 10 years, and the most common location is the head and neck. And you remember when we discussed issue of nasopharyngeal tumors, and we have mentioned that rhabdomyosarcoma is one of the common lesions in the pediatric age group occurring in this particular anatomic location. This is a rapidly growing mass occurring anywhere and has a tendency to invade bone. As most of the sarcomas, there is no specific imaging criteria. 20% of the patients have metastasis at the time of the diagnosis, and these metastases usually go to the lung and the bone marrow. If you look to this plain X-ray, you see a soft tissue mass along the wrist joint and the fifth metacarpal bone with almost no associated bony changes. Rhabdomyosarcoma in the plain film will appear like this with no specific imaging criteria. Sometimes you can detect calcium within the soft tissue mass. On ultrasound and CT, the mass will be of heterogeneous equitexture and density, and whenever you inject contrast material, it will enhance with contrast material. And this is a female patient, 45 years old, with a very big orbital mass. And this mass is heterogeneously enhanced. It has infiltrated the orbit, the maxillary sinus, the ethmoidal air cells, and this was proved to be a rhabdomyosarcoma. Another lesion in the lateral aspect of the thigh showing dense calcification in the at the site of the tumor, and also seen in the CT image, and also here you can see the tumor. This was a rhabdomyosarcoma in this patient who developed the right buttock and hip pain following a fall to this area 6 years earlier, and appeared to develop a hematoma. It was suspected to be a hematoma. Another case of rhabdomyosarcoma by the plain film you have seen before. And this, the CT, the MRI T1 and MRI T2 or stir images, where you can see the tumor of heterogeneous density as well as iso-intensity to the adjacent muscles in the T1, hyperintensity in the stir images. Rhabdomyosarcoma, CT, MRI T1, T2, and contrast enhanced images showing the heterogeneous pattern of contrast enhancement. The differential diagnosis of rhabdomyosarcoma will include other types of sarcomas like Ewing sarcoma and non-Hodgkin lymphoma, fibrosarcoma, angiosarcoma, and synovial sarcoma. Then we came to the lesions arising from the synovial membranes, and these include eight lesions. Number one, the benign cystic lesions like the ganglion and synovial cysts, giant cell tumor of the tendon sheath we have discussed before, pigmented villonodular synovitis also, synovial osteochondromatosis, synovial chondrosarcoma, synovial hemangioma, lipoma are present we have discussed before, and the synovial sarcoma. The benign cysts will include synovial cysts, ganglion cysts, and bursa. Ganglion cyst is a benign cystic lesion which is occurring very commonly in the hand and wrist region, and about 70 to 80% of the cases are seen in this particular area. They occur commonly in young women, and the etiology is not well appreciated. Myxoid degeneration in the joint capsule or the tendon sheath may be the underlying etiology. They are typically attached to the underlying joint capsule or the tendon sheath, and these ganglion cysts may occur after trauma or surgical interventions. Ganglion cysts can occur in the muscle, in the meniscus, you remember parameniscal cyst, in the ACL, you remember also crochet ganglion cyst, in the tendons, and even in the bones. The majority of these cystic lesions are hypoechoic, containing synovial fluid, and they have well-defined margin with posterior acoustic enhancement similar to any cystic lesion on ultrasound. On MRI and CT, the lesions may be unilocular or multilocular, showing in the fluid density and signal. In the T1 is low, in the T2 and the stir image is high signal, and sometimes you got increased signal in the T1 weighted image due to the proteinaceous or hemorrhagic components of the lesions. And this is an example of a ganglion cyst in the region of the wrist joint. You can see a multilocular lesion of bright signal in these stir images, diagnostic of ganglion cyst. And this is also one of the well-known ganglion cysts related to the cruciate ligament, showing low signal in the T1 and high signal in the T2 weighted image. This is known as cruciate ligament ganglion cyst or intercondylar notch ganglion cyst. Also, a cystic lesion in the suprascapular notch, and the lesion showed low signal in the T1 and the high signal in the T2 weighted image. Of course, you know that this area, the suprascapular nerve is present, and also the suprascapular artery. There may be some compression on the nerve, resulting in this nerve entrapment or neuropathy. And this is an example of multilocular ganglion cyst in the back of the knee. And you see the fluid signal in these T2 weighted images in the axial, coronal, and sagittal images. Then Baker cyst is one of the well-known synovial cysts occurring in the popliteal fossa between the head of the gastrocnemius and the semimembranosus muscle. And this Baker cyst is not a true bursa and not a true cyst. It's continuous with the joint, and they usually fill with the joint, fills with fluid when the joint is containing effusion. Then the lesion is frequently detected incidentally. If it ruptures, it will lead to extravasation of the synovial fluid into the calf, and this will represent by acute symptoms which are similar to deep vein thrombosis. By ultrasound, by CT, by MRI, the lesion looks like the speech bubble with an echoic appearance, and it contains fluid on CT and MRI. Some debris may occur inside the lesion, and this is what we mean by the speech bubble, meaning that there is a cyst with a pedicle or a neck, and this neck connects the cyst to the joint space. And this is another Baker cyst in the popliteal fossa, showing the classic speech bubble appearance in both these two T2 weighted images. Now we came to the bursa, and bursa is a small fluid-filled sac lined by synovium with synovial fluid inside. The bursae are located in many places all around the body, and there are specific locations of the bursa, like this one, the olecranium bursa, which is the very famous, and inflammation of this bursa is usually seen in the clinical practice. Bursa is usually empty unless it is inflamed or some fluid came from the joint to the bursa, and at that time the bursa will accumulate fluid and it will appear on imaging. And this is a big list of the bursae all over the body, especially in the famous anatomic locations like the subacromion subdeltoid bursa, the subscapularis, the subcoracoid bursa, the coracoclavicular, and the supraacromial bursa. And the knee, the infrapatellar, the prepatellar, the suprapatellar, Baker cyst, bis and serine bursa, medial collateral ligament bursa. In the ankle, the famous retrocalcanean bursa. In the hip, the largest bursa all over the body, the iliopsoas bursa, trochanteric bursa, subgluteus medius bursa, and minimus bursa, obturator externus bursa, and internus bursa. SQ gluteal bursa, in the elbow, olecranian bursa, subcutaneous bursa of the medial epicondyle and of the lateral epicondyle, and bursa of the ankylosing muscle. This is just an example of olecranian bursitis we have discussed in details in the lecture of the elbow joint. You got these are the causes: excessive use, like the student elbow, active repetitive trauma, septic inflammation, or in cases of rheumatoid or gout and other. And in the X-ray, you see a soft tissue swelling in the back of the elbow, and sometimes you see calcium if the underlying cause is gout or the pseudo gout. Then this is prepatellar bursitis. You got some fluid accumulation in the subcutaneous region anterior to the patella, low signal in the T1, high signal in the T2, and the high signal in the STIR images. Synovial osteochondromatosis is one of the lesions that affect major joints, especially the knee, the hip, and the elbow, with the age incidence around 40 years, and with some male predilection. The primary type is due to metaplasia of the synovium into cartilage. The secondary type is usually secondary to osteoarthritis and maybe the trauma. Many of the loose bodies can be identified within the joint space, and these loose bodies may or may not calcify. If they are calcified, you can detect them by X-ray. If not, MRI and ultrasound can see these lesions very clearly. The lesions will result in widening of the joint space, later on erosion of the articular cartilage, and the development of secondary osteoarthritis. And this is the appearance by MRI, T1 weighted image, and T2 Raster weighted images. The lesions, if they are calcified, they appear black in all pulse sequences, and some larger lesions may contain bone marrow, so they will appear similar to the bone marrow signal in the different pulse sequences. And this is the plain film showing multiple loose bodies in the back of the knee as well as anteriorly. And in the MRI, you can see the loose bodies of black signal. You remember lipoma arborescens is a front-like fatty mass present within the synovium surrounded by synovial fluid. The incidence is about 1% of all lipomatous lesions, and it is seen usually in the fifth to the seventh decades of life. And usually there may be osteoarthritis or collagen vascular disorder, and sometimes there may be a history of trauma. There is joint swelling and variable degrees of joint pain or arthralgia, and frequently joint effusion as well. And this is the classic appearance of lipoma arborescens, an intra-articular mass made of fat with front-like projections. And you remember, if the mass is just a soft tissue mass within the joint space made of fat with no projections, and this is known as synovial lipoma. If these projections are present, then you call it lipoma arborescens. In MRI, the lesion will show the same signal intensity of fat in all pulse sequences with T1 and T2 bright signal and suppression of the fat and suppression of the lesion in fat suppressed images with no post-contrast enhancement. In the plain film, you see just the joint swelling suggestive of the presence of effusion. On MRI T1 weighted image, you see high signal lesion surrounded by fluid, and in the T2 weighted image, you got suppression of the fat similar to the bone marrow fat and is surrounded by a considerable amount of joint effusion. Lipoma arborescens can sometimes simulate loose bodies, synovial osteochondromatosis, pigmented villonodular synovitis, synovial hemangioma, and just synovitis due to any cause of inflammation. When we came to the one of the important lesions, which is the synovial sarcoma. And synovial sarcoma is a common intermediate to high-grade malignant soft tissue tumor. It accounts for 6% of all soft tissue sarcomas. It affects young patients, and this is an important issue in the diagnosis of synovial sarcoma. It affects young patients in the range of age between 15 and 40 years. Number two, which is very important, it is a slowly enlarging soft tissue mass, which many times give an impression of a benign lesion. Then this tumor particularly seen in young persons, and it has a slow progressive course. The most common location for these tumors is the popliteal fossa, and this is important also. They do not arise from the synovial structures. The name synovial sarcoma is a misnomer like rhabdomyosarcoma. Rhabdomyosarcoma do not arise from the striated muscles, but it differentiates into what looks like striated muscle, and also this tumor do the same appearance. Other locations include the head and the neck. The head and the neck do not contain synovium, the chest wall, and the abdominal viscera. The treatment is a combination of surgery and neoadjuvant radiotherapy or chemotherapy. This is an important statement. Synovial sarcoma derives its name from the fact that microscopically it resembles normal synovium. However, it stands for epithelial markers like epithelial membrane antigen and cytokeratin, which synovium does not. Additionally, it has been found in many locations that do not normally have synovium. And synovial sarcoma is not of synovial origin. And you see here in the X-ray, one of the prominent features of synovial sarcoma is the presence of calcium. And calcium is present in up to 30% of the cases. This is a famous situation or famous location for the synovial sarcoma, and it may be associated with pressure erosion of the underlying bone. The tumor occurs in young persons and is slowly growing. It contains calcium and can be associated with pressure erosion. All these criteria may lead to the misdiagnosis of a benign tumor. Bony invasion is seen in 30% of the cases with aggressive bone destruction. And this is a common location and the common appearance of synovial sarcoma. A lesion which is located in the back of the knee and it contains some matrix calcification with no significant bony changes of the related bones. Synovial sarcoma has no specific imaging criteria, but if you see the tumor, which is near a joint and is seen in young age and it contains calcium, then you may think of the presence of a synovial sarcoma. Here you see aggressive bone destruction of the fourth metacarpal bone with an infiltrative soft tissue mass in the hand. This was pathologically proved to be the synovial sarcoma. Synovial sarcoma will have vascularity seen on Doppler imaging, as you can see here. There are some of the imaging criteria or imaging signs which may help in the differential diagnosis of synovial sarcoma from other sarcomas. These signs include number one, in MRI T1, the tumor is relatively hyper intense to the muscle. It has an intermediate signal. In the T2 weighted image, the tumor is hyperintense, and there is a mixture of three signal intensities on T2 weighted image, hence the sign triple sign. These signal intensities are the combination of high signal due to necrosis and cystic degeneration, intermediate signal due to soft tissue component, the dark signal due to dystrophic calcification and fibrotic bands. And this tumor may bleed and there might be areas of fluid level, and this is simulated by what is known as the bowl of grapes sign. I don't actually find a good relation between this appearance and the appearance of synovial sarcoma, but is frequently mentioned in the literature. If you inject contrast material and you got enhancement of the solid component. Then here you see a lesion which is near the joint, especially the knee, of course, in a young age with some calcium. The tumor is of low signal in the T1 and high mixed signal in the T2 weighted image with heterogeneous post-contrast enhancement. This is an important statement. The finding of a soft tissue mass with calcification close to a joint in a young patient should strongly suggest the diagnosis of synovial sarcoma. Pigmented villonodular synovitis do not contain calcium. Pigmented villonodular synovitis shows low signal in the T2 due to hemosiderin. It does not contain calcium, so you can easily discriminate between both. Synovial sarcoma, there are two major categories. The category with good prognosis, and this include the small size, extremity location, young age, solid homogeneous mass, then the presence of calcium. These are the criteria of a lesion with relatively good prognosis. But a lesion with poor prognosis include large size more than 5 centimeter, and this is the most important prognostic factor, is the size of the tumor. Number two, location in the trunk or in the head and the neck. Old patient, the presence of cystic and hemorrhagic components. The overall 5-year survival rate is about 55%. The local recurrence rate is about 40%, and distant metastasis is about in the range of 55%. Metastases are usually to the lung, bones, lymph nodes, and this is important, and the chest wall as well. And here you can see a mass in the thigh, or and this mass of uh, non-specific imaging criteria. The differential diagnosis will include other types of sarcomas, like the pleomorphic undifferentiated sarcoma, which is the new name for adult type fibrosarcoma, and the malignant fibrous histiocytoma. Then liposarcoma, undifferentiated liposarcoma, we have the same finding. Osteosarcoma, chondrosarcoma, and the metastatic deposit. Then we came to the tumors of the peripheral nerves, and they are four. Number one is schwannoma. Number two is neurofibroma. Number three is the plexiform neurofibroma. And number four is the malignant component of these, which is now known as malignant peripheral nerve sheath tumor, not a neurofibrosarcoma. The malignant component is known as malignant peripheral nerve sheath tumor. And schwannomas are considered the benign lesions arising from the Schwann cells, and by WHO is considered the grade 1 tumor. This is the most common tumor of the peripheral nerves, as well as the cranial nerves. Neurofibroma do not arise usually from the cranial nerves. The peak of presentations is between the fifth and the sixth decades, and if it is a part of the neurofibromatosis type 2, it can be seen in younger persons in the range of the third decade. Multiple schwannomas are characteristic of neurofibromatosis type 2, especially the acoustic neuron. Schwannoma is characterized by three E's. Number one, encapsulated tumor, eccentric location, easy surgical removal from the parent nerve. And you see here that the schwannoma is eccentric, and you can remove it with the nerve is almost intact. And this is in contradistinction to the neurofibroma, which circumferentially involves the nerve. This is schwannoma is a well circumscribed mass displacing the adjacent structures without invasion. The cystic changes are common, and this is also one of the differentiating points between schwannoma and the neurofibroma. Hemorrhage occur in about 5% of the cases, and calcium is rare in both schwannoma and the neurofibroma. CT will show hypodense mass because of the cystic changes. Large tumor may show heterogeneous enhancement, and if the adjacent bone will show some smooth indentations or scalloping, this is a benign lesion. In the T1, it is hypointense or isointense. It will enhance after contrast injection. T2 hyperintensity, the cystic changes will appear high signal, and the T2 star or gradient images may show blooming due to the presence of hemosiderin due to hemorrhage inside the tumor. And then we have the signs of nerve cell tumors. These are important signs, and they are not specific but can help in the differential diagnosis. The first sign is known as the split fat sign. And if you look here and you see the tumor, and you see that the fat is encasing the tumor from its back and its front. And this sign indicates that this is a benign lesion with no infiltrative characters, but it is not specific for the schwannoma or neurofibroma. Number two is the target sign, where you can see peripheral high signal intensity surrounding a dark signal intensity core. And this is well known for neurofibromas and can be seen also in schwannomas. The fascicular sign, and this sign you see the tumor with internal minute intermediate signal representing the nerve fascicles. And this is one of the signs also that is characteristic for neurogenic tumors. Then the split fat sign is the presence of fat at the upper and the lower poles of the region of the lesion. This is not specific to a neurogenic tumor. It is a feature of a benign lesion. And you see this is a well circumscribed lesion with fat above, fat below, and this may help you to think of a benign lesion and a fibroma, a neurofibroma and schwannoma are included in the differential diagnosis. By MRI, you see the tumor of the bright signal in the STIR image, and in ultrasound, you see a well circumscribed lesion with some vascularity inside on Doppler imaging. And this is a good example of schwannoma. It has a hyperechoic and a peripheral hypoechoic bands with significant posterior acoustic enhancement. And neurofibroma, or neurolymphoma, or schwannoma in the tarsal tunnel. You see the lesion is of low signal in the T1, high signal in the STIR, and significant contrast enhancement after contrast injection. Schwannoma and the neurofibroma are well known in the head and the neck, especially in the space posterior to the parapharyngeal space, and it shows the similar criteria like the enhancement and the characteristic location. And this is a schwannoma in the leg. You can see the tumor of almost iso-intense signal to the muscle, high signal, and the T2 significant contrast enhancement with the fascicular sign. In the sagittal and coronal images, you may identify the split fat sign, where you can see fat along the upper and lower pole of the tumor. Then one of the important criteria of neurofibroma in particular, not the schwannoma, is what is known as the nerve entering sign. And you see the tumor with the nerve going inside and nerve going outside. This is known as the tail sign or the nerve entering sign. And this is also a schwannoma near the knee, where you can see the tumor in the T1 fat set, and in the T2 with fat set, you can see the target sign. And if you inject contrast material, the central part of the lesion will enhance, and the peripheral part of the lesion will not enhance. And neurofibroma is the second tumor in this category. It is a tumor of the peripheral nerves, and is usually solitary. Sometimes it can be multiple in the course of the well-known neurofibromatosis type 1. The peak of presentation is between 20 and 30 years of age with no sex predilection, is also considered by WHO as a grade 1 benign lesion. The transformation into the malignant form occurs in about 5 to 10% of these tumors. The tumor is well defined. It may show some contrast enhancement. It has a fusiform appearance along the course of the nerve. The tail sign is evident here. Nerve enters and leaves through the central part of the tumor with no capsule, no peritumoral edema, similar to the muscle in the T1 and increased signal in the T2 weighted image. The target sign is where you can see the nerve is going inside the tumor and coming outside the tumor. The target sign is common in neurofibroma and less common in schwannoma because schwannoma is an eccentric lesion, but the neurofibroma is centered to the course of the nerve. Then the lesion will show homogeneous contrast enhancement, and the affection of the nerve may lead to muscle atrophy of the muscles supplied by the affected nerve. And here you see the target sign. This is T1 weighted image, a lesion of intermediate signal similar to the muscle. In the T2 weighted image, you can see the appearance of a core of low signal intensity surrounded by a margin of high signal intensity. If the lesion demonstrated the target sign at a certain time and after that the target sign has disappeared, this may indicate that the lesion is transformed to the malignant form. And here you see this schwannoma with a split fat sign and also the target sign in the forearm. You see the central low signal and the peripheral high signal intensity. And this is the neurofibroma in the back of the knee showing intermediate signal in the T1, high signal in the T2, and after contrast enhancement, and you got almost homogeneous post-contrast enhancement. Now we came to the third category in this group, which is the plexiform neurofibroma. It is an uncommon variant of neurofibroma, also considered as grade 1 lesions by WHO, commonly seen in the childhood. It is a diffuse lesion. As you can see here, this is a plexiform neuroma of the back of this patient, and it essentially pathognomonic for neurofibromatosis type 1. And the tumors are at a significant risk of malignant transformation. The malignant transformation is in the range of 5 to 10% of these large tumors. The imaging findings are non-specific, but they can be well appreciated from the clinical point of view and also some of the imaging criteria. The differential diagnosis is from other large lesions like lymphatic malformation, venous malformation, and sometimes some of the sarcomas in the limb. And this is a plexiform neurofibroma of the neck, a huge mass made of small lesions of neurofibromas extending into the mediastinum. Then this is also a female patient, 14 years old, with known to have neurofibromatosis type 1. The images show a big mass infiltrating the root of the neck, extending into the axilla, low signal in the T1, high signal in the T2 and the stair, with heterogeneous post-contrast enhancement. Then finally, we came to the malignant component of the previously mentioned lesions, which is the malignant peripheral nerve sheath tumor. And this is the malignant form of neurofibroma and schwannoma, represents about 5 to 10% of all sarcomas, and account for 50% of such tumors are seen in patients with neurofibromatosis type 1. And this typically presents in young and middle-aged adults with a high frequency in individuals treated by radiotherapy. Then the tumor is often large, more than 5 centimeters in diameter, and may infiltrate the surrounding tissues. This malignant peripheral nerve sheath tumor is an aggressive one with poor prognosis, and patient develops metastasis in about 20-25% of the cases. Poor prognostic factors include the presence of neurofibromatosis type 1, large size of the tumor, tumor in the trunk, and high-grade histologic features. This patient, 24 years old with neurofibromatosis type 1, having a big mass in the thigh with heterogeneous post-contrast enhancement and pathologically proved to be malignant peripheral nerve sheath tumor. There are no imaging criteria to differentiate this tumor from the remaining sarcomas in the body. However, the general rules favoring the malignant peripheral nerve cell sheath tumor include large lesions are more likely to be malignant, irregular borders, rapid growth in interval imaging. This is a lesion related to the zygoma on the left side in this female patient. It shows some hyperdensity in the CT scan, low signal in the T1, high signal in the T2, and the peripheral post-contrast enhancement. And this lesion is not suggestive of a specific entity, but it was proved to be a malignant peripheral nerve sheath tumor. And this is also another example. And you see a lesion which is in front of the leg and is of low signal in the T1 and the high signal in the T2 weighted image. Another example of this malignant schwannoma or malignant peripheral nerve sheath tumor, in the CT scan, you see a mass of almost similar density to the muscle with its intense post-contrast enhancement. And according to the literature, the differential diagnosis include carotid body tumor, malignant peripheral nerve sheath tumor, and hypervascular metastasis. And according to the literature, also two or more of these features can be considered highly suspicious for malignancy. As I have mentioned before, large size of the mass, more than 5 centimeters in diameter, peripheral enhancement commonly seen in the malignant lesions, perilesional edema-like zone, intratumoral cystic changes commonly seen in schwannomas and malignant lesions, heterogeneity on T1 weighted images, especially in patients with neurofibromatosis type 1. And this is T1, T2, and post-contrast of a mass in the back of the thigh, and it was proved to be a malignant peripheral nerve sheath tumor. This is a retroperitoneal mass, a low signal in the T1, high signal in the T2, and high signal in the stair with some contrast enhancement. This mass is for differential diagnosis, and there is a big list of the differential diagnoses, including liposarcoma, of course, malignant fibrous histiocytoma, leiomyosarcoma, rhabdomyosarcoma, fibrosarcoma, malignant peripheral nerve sheath tumor, hemangiopericytoma, extragonadal germ cell tumor, primary retroperitoneal adenocarcinoma. These are the differential diagnoses suggested by the literature, and the tumor was proved by biopsy to be a malignant peripheral nerve sheath tumor. Thank you very much. Alhamdulillahi Rabbil Alameen.